I am David Craig, the CEO of Grit Health, and I am honored to welcome you to the Advocacy Exchange for our session today around international health technology assessment and their impact on access and patient preference. Before I welcome our first speaker, I just want to share with you why this topic is not only important, but such a significant part of my life. And the reason for that is my first cancer diagnosis happened when I was 25 years old. I had a different cancer diagnosis when I was 30 years old. And most challenging in my life was my father's passing from cancer when I was 35 years old. And during that 10-year period, I can honestly tell you that I was full of anger about the ways the system didn't work or the ways I thought we weren't supported in how we needed to be. And it is for that reason that I became an advocate in 2012, to be a part of creating change with others who cared so passionately about doing that. There's a quote I heard one time that our ability to change a situation is directly proportional to our understanding of it. And it is for that reason that I'm so grateful that I get to be a part of this advocacy exchange and a part of the world that so many people are working with everything they have to improve. This advocacy exchange program has been co-created with advocates from around the world, and all of these session topics and the agenda and what we share comes from a cross-cultural, cross-stakeholder, cross-therapeutic area to really dig into these incredibly complex issues in a way that they need to be dug into. And so I'm grateful that you're a part of this conversation today. The speakers who you will meet in just a moment, some I have known since I became an advocate in 2012, and some I have just recently met. But I can say with all of my heart that they are some of the most sincere and genuine people I've ever met. And so with that framing, I have the honor and the pleasure of introducing our opening speaker, Mike Ryan. Mike is the Senior Vice President and Head for US and Worldwide Value, Access, Pricing, and Health Economics and Outcomes Research. And in our prep with Mike, Mike, you were sharing your 20 years in academic healthcare and our shared background at the University of Michigan. And I'm just so excited for this group to hear all of that perspective that forms your views now. So everybody, please give a warm welcome to Mr. Mike Ryan.
Thanks, David. I really appreciate it. Maybe we can start with the first slide. Okay, so one of the things I was asked to do at the beginning of this presentation was to spend a little bit of time talking about why we're here today. And I could state it, but to be quite frank, it's better if we just stare at some statistics on US healthcare, because I think it becomes really obvious when you see these statistics. So we're going to quickly run through a series of statistics that I think are important for people to know. Next slide. There we go. Okay. In the upper left-hand corner of this slide is a slide that helps you look at what is the healthcare spending as a percent of GDP. As you can see in the upper left corner, the US has the highest healthcare cost amongst all OECD countries. This is one of the reasons why people are so concerned about healthcare in the United States. On the upper right-hand side, you can see that this carries through to patients, that almost 1/4 of all Americans say they're having difficulty affording their prescription drugs, with more than 50% of them spending more than $100 per month on their prescription drugs. However, in the lower left-hand corner, it's interesting to note that prescription drugs have one of the lowest rates of growth of all US healthcare expenditures. And on the right, if you look at healthcare expenditures as a percent of total healthcare spending, that pharmaceutical spending as a percent of total healthcare spending is one of the lowest of all GDP countries in the United States. So you've got to be asking yourself, after all you've heard in the press, how can prescription drug costs be among the lowest as a percent of total healthcare costs compared to other countries? The answer is in the upper left on this graphic in the next slide, which shows that when you look at what's driving the difference in healthcare spending between the US and comparable countries, it's driven by inpatient and outpatient costs and administrative costs. They make up almost 90% of the difference between healthcare costs in the United States and other countries, while pharmaceuticals only make up about 10% of that cost. So why are US patients so concerned about the rising cost of drugs? To answer this, take a look at the upper right-hand corner, because you have to first understand the patients are not concerned about the cost of drugs. They're concerned about the rising cost of what they are paying for drugs. Then look at what's happening with patient insurance premiums, which is the blue line in this graphic, up 175% since 2002, and deductibles, which is the green line, which is up 90% since 2002. In fact, the percentage of plans with deductibles has increased 83% since 2006. The fact is, health plans are requiring patients to pay more for their health care than in the past. As you can see in the lower left box, when it comes to deductibles and patient out-of-pocket expenses, patients pay far more for prescription drugs than they do for physician services or for hospital services. Nonetheless, irrespective of political affiliation, politicians are focused on drug cost rather than the inpatient and outpatient administrative costs that make up 90% of the issue. And there is a broad agreement across US voters on the need to lower prescription drug costs. And that brings us to the reason of why we're here today. Next slide. Some politicians and organizations are beginning to look to Europe for solutions and advocating for the adoption of a US government-driven health technology assessment, drug access and pricing program. You've seen this on the campaign trail with Joe Biden when he talked about implementing an HTA drug pricing negotiation program that is similar to Germany's national system. You've seen Aaron Kesselheimer from Harvard Medical School suggest that the US develop a centralized health technology assessment program, and ICER could serve as an input in a national program. And probably most concerning, and we'll talk a little bit later about why, you've got the quote from Steve Pearson here about employers looking to use specific cost per quality of adjusted life year information as a determining factor for reimbursement, access, and formulary design. Next slide. So let's start by talking about what HTA is. And so, but before I get too much into HTA, I must warn you that HTA can be quite complex to explain and to understand. However, it is exactly this complexity that hides many of the limitations and flaws of HTA. So it's important that everyone have at least a minimal understanding of the terminology used in HTA and how the calculations are performed. Next slide. So HTA is defined as a multidisciplinary process that uses explicit methods to determine the value of health technology. In its simplest form, HTA involves the use of a quality of adjusted life year, which attempts to combine the value of a drug on life expectancy and or quality of life into a single measure by multiplying the assumed impact the drug has on life expectancy or health state times a cost utility value that is assigned to that patient population that is being treated. This cost utility value can range from 0 for death to 1 for perfect health. We'll talk about it later, but in determining a quality of adjusted life year, the value of 1 year of life for an elderly person or someone who has a chronic disability is valued less than the same 1 year of life for a healthy younger person. The incremental costs and qualities for the proposed treatment are then compared to those of the current standard of care to come up with what's called an incremental cost effectiveness ratio, or ICER, not to be confused with the Institute of Clinical and Economic Review that's run by Steve Pearson. The ICER measure then compares the cost per quality of adjusted life year improvement of the proposed therapy versus the standard of care, and is then compared to the willingness to pay threshold for that particular HTA or country. And as long as the ICER is below the willingness to pay threshold, the therapy is approved for reimbursement. It's important to note that the cost utility values and willingness to pay thresholds vary dramatically from country to country, and that HTAs utilize population level data in their quality of adjusted life year calculations. HTAs assume an average best therapy for the population, They do not take into consideration the full heterogeneity of an individual patient treatment effect. Hence, economists agree that QALYs should never be used in clinical decision-making for individual patients. Next slide. HTA originated in the 1990s in the UK and the EU and is widely used as a single-payer and widely used in single-payer healthcare systems to control the cost of pharmaceutical innovation. There are several different types of HTA processes. Some countries, like Germany, evaluate the added clinical benefit of new drugs versus the existing standard of care. Others, like the UK, Canada, and Australia, assess the cost effectiveness of new drugs versus the added cost. While other countries, like Italy and Spain, will utilize an estimation of the impact that a new drug may have on the healthcare budget or a budget impact analysis in their determinations. There is no one best HTA, and each comes with significant trade-offs between containing costs and providing timely access to innovation. HTA has recently expanded into Asia. It's seen now in South Korea, Taiwan, Japan, and China, and on a private non-governmental basis in the United States. In addition, we're also beginning to see centralization of HTA across regions, with the EU looking to initiate a centralized HTA process by 2024, and the UK evaluating potential partnerships with Canada and Australia. Next slide. So let's spend a little bit of time talking about the limitations of health technology assessment and cost-effectiveness analysis. Next slide. When discussing the limitations of HTA, one must start with the fact that the calculation and input into what is considered value varies dramatically from HTA to HTA. The slide below shows the International Society of Pharmacoeconomics and Outcomes Research, or ISHPOR's, value flower, which is basically a listing of the various components of value that can be considered in an HTA assessment. Unfortunately, most HTAs consider only a small fraction of these elements. The dimensions of value most often include things such as clinical effectiveness, safety, costs, and economic implications. Less frequently, they may include ethical, social, cultural, and a wider implications for patients, relatives, and caregivers. What elements of value are considered in an HTA cost-effectiveness analysis often varies depending on the perspectives taken by the owner of the HTA process. Next slide. Unfortunately, I don't have the time to describe the many factors that contribute to variability and how HTAs determine value, but let me just touch on a few elements to illustrate. So let's take a look at appropriate comparators, and what is the appropriate comparator? The standard of care for most disease states varies dramatically from country to country, and it's not uncommon to see globally up to 4 to 5 different standards of care for an individual disease state. Unfortunately, the HTAs require, in these situations, phase-free data showing the comparative effectiveness of the proposed treatment to their standard of care. To accommodate such a request would require multiple arms in your phase 3 clinical trial, which in turn would drive up the cost of development and delay clinical trial results. However, failure to accommodate this unrealistic HTA requirement often results in a poor HTA assessment, and as we'll see later, delays in access to innovative therapies in these countries. When you look at study endpoints and mature versus immature data, it's important to note that it's not uncommon for a foreign HTA to not accept the study endpoints that are considered valid in the United States. This is seen across multiple disease states, but perhaps is most important in oncology, where ex-US HTAs often do not consider progression-free survival as a valid clinical endpoint. The recognition of the predictive value of progression-free survival to anticipate a positive overall survival result years before the actual OS data reaches statistical significance has allowed the US to receive innovative therapies years in advance of what occurs in most ex-US HTA markets, where progression-free survival is often not considered a valid endpoint. Lastly, let's look at how HTAs project or model, as we often talk about, value after the phase 3 clinical trial period is ended, and how this also drives enormous variability in the perceived cost effectiveness of pharmaceutical innovation. What you see on the left in this slide is the results of a study that was performed by Bulleman and colleagues at the University of Sheffield in the UK, and that evaluated the accuracy of modeling techniques employed by the UK HTA NICE to project the future value of mono-IO therapy after a 3-year trial period was completed in the trial of advanced melanoma. And so, just to orient you to the slide, what you see is that the treatment period ended at year 3, and then you're looking at how they forecasted the period between years 3, 4, and 5. And what you see is a blue line on this. The blue line is what NICE employed. It used a method called parametric modeling, and I won't get into the details of it, but it's a fairly conservative method for projecting overall survival after the study ends. The orange line on this is actually the line that was turned in by the pharmaceutical company at the time of the HTA assessment. Then what Bulleman did is he obtained the continued data from patients who were on this trial in years 3, 4, 5, and 6, and then actually assessed and measured what the actual overall survival was in those years. That is the dotted line. And what he showed is that that dotted line had a significant, almost 2-fold higher actual overall survival than what had been projected by NICE. Bulleman concluded that the modeling techniques chosen by HTAs have a profound effect on the perceived value of and access to innovative therapies, and that the models employed by NICE undervalued the projections of future overall survival seen with this therapy in advanced melanoma. And his analysis validated the use of what's called mixed cure fraction modeling, which is where you assume a proportion of the patients achieved a cure, as originally was recommended by the pharmaceutical company in its original submissions. On the right-hand side of the slide are the results of a later submission to NICE for the approval of combination IO therapy in advanced melanoma. In this case, NICE accepted the use of mixed cure modeling, which resulted in an improved quality of adjusted life year that was almost 2-fold higher than would have been seen with their standard modeling techniques. This in turn led to an incremental cost effectiveness ratio that was nearly half of what otherwise would have been projected, and resulted in the combination therapy being considered cost effective and granted rapid reimbursement approval and access. Similar retrospective reviews of HTA modeling to what Bulleman did in this trial have consistently shown that HTAs employ overly conservative modeling techniques and have thereby systematically undervalued and delayed access to pharmaceutical innovations. Another concern, next slide, another concern about HTAs is that the quality of adjusted life year framework can be discriminatory. The QALY uses as a definition perfect health and longevity, and it implies that a younger person with no underlying health concerns. This means that patients who currently have a hard ceiling on the amount of QALYs they can gain because of age, incurable conditions, or disabilities can never benefit from the same degree as an ideal patient. What you see in this slide is an illustration of that, with a patient who was born with paraplegia versus patients not born with this disability. For a patient born with paraplegia, they would be signed a cost utility measure, as we talked about. In this case, it would be less than 1, and in this case, it's 0.75, compared to the normal healthy patient who's not born with paraplegia would have a value of 1.0. So for a patient with paraplegia, they will by definition have a lower QALY, which means a higher ICER, and therefore will be less likely to have their therapy be below the willingness to pay threshold and thereby deemed cost effective and be made available, or in some situations for the research to even be conducted in their disease state, given the fact that the companies themselves will know that they have a much higher bar. The potential of QALYs to be discriminatory caused the authors of the Affordable Care Act to legislatively prohibit HHS secretaries from utilizing QALYs or any similar measure as a threshold to determine coverage, reimbursement, or incentive programs under ACA. This is the reason why we don't see government HTA in the United States and instead have private, non-governmental HTA organizations. In addition, the next slide, President Biden and HHS were noticeably silent on the concept of a national governmental HTA program and clearly rejected the use of QALYs in their recent September 9th, 2021 drug pricing plan, noting, quote, "There are important concerns about the equity implications of certain methodologies, such as quality of adjusted life years, for people of all ages and ages with disabilities and chronic conditions. Drug pricing reforms should avoid utilization of methodologies that adversely impact access to needed medications for vulnerable patients and populations." In response, ICER is likely to replace the quality of adjusted life year with an equal value of life years gained metric. Using this metric might address to some extent concerns regarding age and disability bias, but it does not remove the many other major quality of adjusted life year and HTA limitations. In a nutshell, as a colleague of mine once pointed out, we cannot solve our problems with the same thinking we used when we created them. Lastly, it's important to note that there are numerous studies that have shown that HTA cost-effectiveness analysis is a subjective science and that it's subject to significant variability and ownership bias. The attached graphs are just the results of just 2 studies. And I encourage you to ask John OBrien during the panel discussion about MPC's recent results as well. In the upper left shows the results of an Avalier study where they evaluated the HTA assessments and recommendations for oncology drugs performed by 4 different HTAs. From left to right, they evaluated the UK's NICE program, Canada's CAF, Germany's IGWIG and GBA, and France's HAS. I know that the graph can be hard to read, but focus on the blue bars. That represents the percent of recommendations where the HTAs have agreed that the therapy is cost-effective and should be approved without restrictions. As you can see, it varies from a low of 0% in Canada to 5% in the UK versus 50 to 65% in Germany and France. The study on the right is a similar study that was conducted by French researchers that looked at the degree of agreement between HTA reviews performed in Germany and France. Again, the graph can be hard to read, but focus on the darkest sections of the brown bars, which represents agreement between Germany and France's HTA recommendations. As you can see, it varies from a low of 25 to 30% agreement for anti-neoplastics, anti-infectives, and cardiovascular drugs to 80 to 90% for metabolic and CNS drugs. One has to ask oneself, how reliable and accurate can the science of HTA be if we consistently see this level of variability in results and recommendations? Clearly, there is a high degree of ownership bias in how HTA is employed between these countries. Next slide. Lastly, let's discuss the impact of HTA on patient access. Next slide. HTA has been shown to delay access to innovative therapies and foster inequalities in access to quality healthcare. The graph below are data from FPIA that shows the median time to reimbursement after EMA approval in a number of HTA countries. As you can see, delays in access are common and may be as high as 600 to 800 days, while in the US, these therapies are immediately available after FDA approval. The median days are 320 days for all therapies and 352 days, almost an entire year, for oncology therapies. In addition, we often see development of private markets in these countries or patients traveling to the US or other countries to get innovative therapies not available in their home countries, leading to further issues of inequity and access to quality healthcare. Next slide. HTA methodology may also undervalue U.S. patient lives. This is data from Accenture, where they applied HTA cost per quality of adjusted life year figures from ICER to U.S. drugs in a number of classes and found that 59 to 93% of the drugs would not meet the current ICER willingness to pay thresholds, and hence may not be available in the U.S. if it were to adopt a national healthcare, national technology assessment program. Next slide. So in conclusion, the variable subjective nature of cost utility indices, willingness to pay thresholds, what constitutes value and how it is calculated and extrapolated, along with the potential concerns of discrimination and delays in access to healthcare that are associated with it, there can really be little argument that HTA-driven quality of adjusted life year assessments are a lower hierarchical science, far lower than systemic reviews, randomized clinical trials, or even observational trials. This is a particularly concerning issue when the science of HTA is portrayed as having the capability of determining accurate and irrefutable exact point estimates of value that can be used to determine therapeutic access for patients. Hence, the U.S. should move cautiously and should not implement a mandatory national HTA until it can ensure that many limitations of HTA, some of which are outlined in this slide, are adequately addressed. So I want to thank you for your time and your attention. It's my distinct honor to introduce the next speaker, who is Stephanie Dyson. Stephanie is the Vice President and Head of U.S. Policy and Government Affairs at Bristol Myers Squibb. Stephanie has already had a distinguished 20-year career as a health policy strategist and government affairs executive, focusing on a wide array of issue areas in both private health sector and in government. As a registered nurse, she brings a unique patient-centric perspective to a wide array of issues impacting patient access and value. Please join me in welcoming Stephanie Dyson.
Great. Thank you, Mike, so much for that introduction, and welcome to our panelists and the guests. As Mike stated, I'm a registered nurse by background, so I'm really accustomed to translating complex issues and terms and diagnoses, quite frankly, into the simplistic terms so they're easily understood. And thank you to Mike for doing just that for this audience for HTA. I want to remind everyone as we begin with our panel discussion that one of the things that Mike stated, if you recall, is that the complexity of HTA is the very phenomenon that really helps to mask the issues that are most relevant and important to us. And more specifically, what's relevant and important to patients and patient access. We have an esteemed panelist today. I have a couple of questions for them. And what I'm going to do is, as I ask each of them their first question, I'm going to have them introduce themselves before answering that first question. But I do want to let the audience know that you can go to the advocacyexchange.com website for more detailed background and information on each of the panelists. And so I'm going to start the questions today with Dr. Elizabeth Franklin, who's the president of Cancer Support Community. So Elizabeth, if you can introduce yourself as you think about this question. I really wanted to start by asking you, how has your organization engaged with HTA systems, and how have you contributed your perspectives and the perspectives of the communities and the patients that you serve?
Thanks so much, Stephanie. And I just want to say thank you to BMS, to Mary Bordoni, to GRIT for holding this. I really appreciate you inviting me to join you today. So as you said, I'm Elizabeth Franklin. I'm president of the Cancer Support Community. And I'll just add to, Stephanie, since you mentioned you're a nurse, I'm a social worker by training. And I think that that's a really important perspective to bring to this discussion. And I'll talk about that a little bit more. The Cancer Support Community has been a leader in bringing the patient voice to HTA and value discussions for many years, but I want to take a quick step back to set the stage for why we got involved. Years ago, in our Cancer Experience Registry, which has over 16,000 patients, we started asking them, and that includes patients, survivors, and caregivers, we started saying, what does value in cancer care mean to you? At the time, it was over 5 years ago, it was a novel question, and answers were all over the place. Some patients talked about what they wanted out of their cancer treatment. Others referenced their loved ones or their relationships with their family or even their oncologist, talking about shared decision-making. They referenced a high quality of life or being able to engage in activities they enjoy. And some talked dollars and cents, right? When you think about value, that may be the first thing that you think about. But many people had no idea what the question meant. And I found that that was the case when I was working on my dissertation as well. I was interviewing cancer patients about value, and out of the 30 patients that I interviewed, none of them understood the question. And so I think that speaks to the complexity of this subject, right? What is value? And the truth is, it means different things to different people. And HTA processes seek to make sense out of the messy, right? They seek to standardize, but that's not the way that we live our lives. We are in an era of personalized medicine. I think about this a lot. If you've heard me speak recently, you've heard me say this. How do we balance personalized and precision medicine with standardization? And the answer is we need to fit the individual needs, values, and preferences of patients into the discussion. And while standards are crucial, they can help make sure that everybody receives the same level of care. They are not flexible enough to precisely fit patient needs. So back to your question, Stephanie, how do we work with HTA bodies? The answer is that we really lean in. I know that, I may not agree with ICER on many, many things, but I think it's incredibly important to bring the patient voice to them. So we share our registry data. We provide patient voices through focus groups and interviews. And I'll also say that I think it's our personal responsibility to call them when they get it wrong. Call them and hold them responsible and say, look, we shared these patients and you didn't adequately provide their voice in the conversation. So I'm proud of the work that we've done to inform the value conversation, and we'll keep doing just that.
Great. Thank you so much, Elizabeth. And I did not know you were a social worker, so I love it. Next, I'm going to go to John OBrien. John is the president and CEO of the National Pharmaceutical Council. So John, again, if you can start by introducing yourself, but the question I'd like to pose to you is, we heard during Mike's presentation that value assessment is really a subjective science, and it has significant variability and, quite frankly, ownership bias as well. So can you speak to some of the some of the research, quite frankly, that NPC has conducted that highlights the subjectivity and subjectiveness of the HTA itself?
Yep. Thank you very much, Stephanie. It's great to be with you, and I'll echo Dr. Franklin's thanks to everyone who made this session happen. I am pleased to round out our healthcare team as a pharmacist and also a caregiver who helps two parents with their cancer care back home in Florida. I've also worked for a health plan, a drug company, and the last two administrations. We at NPC worked with Tufts to design a case study to test ICER's assumptions that they used in their health technology assessment of PARP inhibitors or new medicines to treat ovarian cancer. And what those researchers found when they replicated the review with two different sets of experts, the different assumptions that those experts used actually shifted the cost effectiveness estimates in 9 of 12 cases. And 7 of those cases actually resulted in more favorable estimates than ICER's. So that research showed that ICER's estimates are neither accurate nor precise. And this is problematic because what ICER does after they do their work is they then put out a press release, and the media and policymakers pick up these very fixed dollar amounts. These point estimates send the wrong message to the media and to healthcare decision makers, and patients are the ones who suffer. Now, all value assessments include assumptions, and these assumptions are based on uncertainty. It's the responsibility of the person or entity that's conducting the value assessment to be open and transparent and acknowledge the uncertainty in their model and include the full range of plausible results in the summaries that are intended to support healthcare decision making. So ICER's assumptions drive the outcome of their assessment. And instead of saying it's somewhere between here and here based on our assumptions, by coming out with a point estimate rather than a range of plausible assumptions, they contribute to poor decision-making and ultimately put high-value treatments out of reach for patients like my parents who need innovation in this care. A full link to this research. I tried to summarize it as well as you could, Stephanie, but a full link to it is on our website.
Great. No, thanks so much, John. And let me just remind the audience that you can submit your Q's and A's in the chat as we continue. Our third panelist is Dr. Andrula Ilatheria, and she is the Executive Director of the Thalassemia International Federation. And so again, Dr. Andrula, I'm going to have you introduce yourself as you think about this question. Specifically, as a patient advocate, what can be done when patient perspectives have not truly been fully represented in the HTA process?
Well,
Oh, no worries. Go for it. Thank you.
Thank you very much. So I am very privileged to represent the global thalassemia family and Thalassemia International Federation in particular, and very privileged to be in this very important discussion with experts, and very timely because of the huge advances that have taken place in the area of both management and cure of thalassemia and other hemoglobin disorders, and the authorization of truly innovative therapies, both in the area of management and cure, as I said. And for us, health technology assessment, the existence of health technology assessment, but very importantly, the contribution of the patient is obviously extremely important. And we have been struggling through the years to develop educational programs and awareness programs to a patient population in order to ensure that they contribute in a meaningful and productive way. It has been very difficult. We are aware that a number of countries are in writing having health technology assessment processes, but in reality, the patient participation and contribution is not facilitated or supported in a number of ways so that it can be meaningful. Therefore, in a negative opinion, or in the case that the patient's perspective is truly not taken into account or consideration, or it has not been truly represented in the HTA process, as the question is, there are two pillars to this. Either the patients have not been able to actually represent their position and their perspective in terms of their difficult, cumbersome patient journey, representing, as we know, a chronic complex disease, because they were not sufficiently and appropriately educated in the HTA process to actually give the value to the process, or the HTA process has not taken into consideration even comprehensive perspective provided by the patients. So in such case, sadly, the ways that patients actually could or acquire tools to come back and resubmit their request for appraisal or for recognition of their position and their perspective is also very limited, and this is what we need to expand across Europe. There are countries that are in the map reporting presence of a set of process for reassessment, but in fact very few countries are actually facilitating the reassessment of the patient's perspective by the patients and facilitating their involvement. And therefore, we are looking at authorized drugs that receive negative opinion, for example, and we are really feeling that patients, that the process is failing the patients and they're violating their rights for access to the drug. And at the moment, and despite the comprehensive details we have heard from Professor Ryan, the situation and the reality is that the patients are not at the moment in a position to accumulate that real data that are needed, particularly after conditional approval of innovative drugs, to actually support the resubmission and the reevaluation of the patient's perspective. Therefore, our feeling is that there is a need for more education, more standardization and guidelines, how to guide and capture the real value of the patient's perspective. And we have seen that where there was a strong patient organization, well knowledgeable advocates that knew how to present the value and the quality element into the assessment, we have seen results happening. So our determination and our experience tells us that despite there is so much work going on with HTA assessment, modeling projections, the real patient's perspective is still lacking recognition, and there are many elements why this is so, and even more lacking the opportunity to actually use tools to reopen the assessment of the drug they're interested in. And of course, chronic patients like thalassemia patients with such huge genetic background and equally huge complex clinical outcomes constitute difficult ways of actually assessing the patient's value and perspective, because this is very different across the disease itself, in addition to the country's priorities and the country's HTA assessment process. So my conclusion on this is that we are lacking tools and we need a lot of work to actually make the patient's perspective well integrated into the HTA process.
Thank you so much, Dr. Andrula. It reminds me, my father passed away of non-Hodgkin's lymphoma, so I couldn't imagine if he didn't have access to the care that he needed when he needed it. And Elizabeth, I'm just going to address this question to you. What are the consequences of those delays for patients with life-threatening diseases, especially cancer and other blood disorders? And I'm really trying to pinpoint for the audience what's missing, how do we really help? And then Mike mentioned patient heterogeneity. How do we account for patient heterogeneity?
Yeah, thanks, Stephanie. So HTA has the potential to drive provider choices, payer decisions, and public policy, ultimately resulting in patient access issues, right? And so I was looking at some of the data. In 2018, 42% of payers reported that they follow ICER in coverage decisions for medical benefit drugs. Another study in 2019 found that 65% of manufacturers and payers believe that ICER has a moderate to significant impact on payer coverage and formulary decisions. We have seen state drug utilization review boards incorporate HTA reviews. Companies like CVS begin to exclude drugs on formularies based on their cost per quality, even the Veterans Administration working with ICER. And so HTA has increasingly real-world implications for patient access to therapies. A negative assessment can lead to coverage refusals or utilization management techniques, which we talk quite a bit about at the cancer support community, because things like step therapy, like prior authorization, can really have an impact on the patient journey, cost them more money long-term, create psychosocial distress, and lead to poorer outcomes. So with so much at stake, it is absolutely vital, again, for the patient voice to be meaningfully incorporated into value assessment and HTA. But as you noted, and as the other speakers have noted, that's not always the case, and it's rarely the case. And so the reason that I brought up that I'm a social worker, when I was working on my research around value, I brought a qualitative lens to the discussion. And I think that that's really important, because a quantitative analysis can never tell the full story. While population health approaches are indeed important, they fail those who don't fit that middle of the curve, right? They are the ones who represent most of the population. And I think this speaks to the heterogeneity question, right? If you don't happen to be one of those people who were in the randomized controlled trial, and we know that that's largely white folks, we know that that's largely people with higher education, higher socioeconomic status. If you don't fall into that group of people, your voice isn't necessarily going to be represented. And so HTA takes incredibly complex information with various meanings to different people and dilutes it to precise answers derived through statistical analysis. And don't get me wrong, I understand the importance of it. I understand that there are scarce health resources and that we have to stretch them, but the full story is not being told. So I believe that one way to improve this is bringing thoughtful, qualitative approaches to understand individual values. Again, as a qualitative researcher, I hear all the time people refer to the data that we come up with as messy or anecdotal. And while, of course, that can be true, and you heard Mike talk about the fact that even some statistical analyses and quantitative approaches are subjective, we underestimate the methodological rigor of well-done qualitative research. So building in social scientists like social workers alongside physicians and economists is critical. I can tell you that I have insights as a social worker. I had been in a hospital directly from patients about things they care about that they may not be mentioning to anybody else. And finally, beyond the qualitative, we need to make sure that we're building in PROs and patient experience metrics into clinical trial design. While randomized controlled trials can help us understand performance in a lab, right? We want it to be sterile. We need evidence and insights from the lived realities of patients on the ground. And so this must become an integral component of HTA that is viewed equally and alongside quantitative results. So that's what, if I were in charge of the world, that's what I would do.
A great response. Thank you for that, Elizabeth. I'm going to turn to John. John, I recall a slide that Mike showed that had sort of country-specific timelines to therapy. And so we know that healthcare systems, based on Mike's presentation, are driven by these country-specific cultural, ethical attitudes, quite frankly, towards access to innovation and towards care. So you've worn many hats throughout the United States healthcare system. Are there aspects of the healthcare system that would make it difficult to adopt this centralized HTA system? You often speak about the promise for our seniors, and we have an individual on the line that has brain cancer who is wondering, how does he think about access for himself and care for himself? So how do we think about that promise from your perspective?
Well, Stephanie, thank you. I'm lucky enough in my last job that I got to represent the U.S. on the OECD drug pricing conversations. And when I went to France to meet with the other countries, one thing I learned is that other countries that use HTA have made the decision to cap the amount of money that they spend on healthcare, even if it means that they don't get access to healthcare when or where they need it. And as Mike described, that leads to people in those countries waiting many months or sometimes years to get a medicine after it's been approved. The promise that we've made to our seniors is that we develop the majority of the new medicines, and that new innovation reaches patients when it's available. And I just, as a pharmacist, couldn't imagine trying to talk to my parents or others about the fact that we know the science, we know it's safe, we know it's effective, but it's just not available to you here yet.
Thank you, John. I really appreciate that. It really is an interesting sort of paradigm when we think about patients and advocates and how they can engage. Dr. Andrula, I want to ask you a question about sort of patient advocates specifically, and how can they really engage in the conversation of HTA? So we have a number of organizations that have developed these processes. How do you view this engagement? Can you give the audience a bit of insight on how they can specifically engage?
Well, thank you very much for the question. And I would continue from what Elizabeth has noted. The lived experience of the patients, the real capture of their experience and perspective and position is what gives and what will give value to an HTA. No projection and no modeling will give the real value to an HTA process and to making a drug accessible to a patient when in need and across a disease. Therefore, that's very important and at heart for us. We are aware that patients are participated in a number of HTA process in a number of ways, either through topic selection, as in Austria, Sweden, UK, Germany, or scoping into patient experience, or using national or HTA-provided tools, or members of committees, or hearings, or participating and contributing in consultations in part of advisory committees of the HTA process. But what is at the moment our experience across the countries and across Europe through Thalassemia International Federation's experience on hemoglobin disorders is that the tools and the way the patients are involved in HTA gives confined results, requires strengthening, and the way the patients can participate, the only way is to become well aware of the HTA process of the country, and if possible to have joint HTA processes so that the patient advocates and the competent authorities do not go through this duplication and bureaucratic ways. So for us, only very few countries are actually giving value to the patient's participation. On the contrary, wider across Europe, but also well outside Europe, it's almost absent the contribution of the patient in any kind of HTA assessment, whether that exists or not. Therefore, we need to find ways so that the participation of the patient and the expression and the capture of their perspective is structured, well coordinated, and guidance is provided to contribute. Are they not listening? Oh, yeah. So, sorry, I thought I was not being heard because I cannot see myself. Therefore, engaging patients in these assessments requires a lot of strengthening and collaboration with the health technology assessment bodies at national level, treating physicians, healthcare professionals, and very importantly, improvement of the tools of data collection, evidence-based, so that the data is provided on a continuous basis through the participation of patients in the HTA process.
Great. Thank you, Dr. Andrula. And thank you all for putting your questions in the chat. We've been weaving them into the presentations, as you can tell, as we've gone along. I'm hoping Mike Ryan is still on because we have one question that I think will take us to the top of the hour. And Mike, I'm going to read this because I think this one is explicitly for you. It says, what are your thoughts with sequential participatory research designs, which allow for quicker translational time while allowing for a space for the patient stakeholders' input? So I hope I captured that question correct, Anne-Marie. Mike, your thoughts?
Yeah, certainly it moves the science along faster in the process. And I think as a result, anything that moves the science faster is a benefit to patients in situations. I think the issue is going to be with regulatory agencies and HTAs and others to get them to understand that we're changing the form of which that we conduct that science. And so getting them to really understand that change is going to be something that will be monumentally important.
Great, thank you. We have a question then. So any member of the panel, actually, is there a country that we consider best in class, a best in class program from a patient engagement perspective? I'm going to say,
well, is for Dr. Ryan?
Go for it, Dr. Andrula. That would be great.
Yeah, go ahead.
Well, I have to confess our experience with regards to thalassemia, but some of the countries with very strong patient associations like Italy, Greece, and Cyprus have a very strong patient involvement and quite successful representation of the patient's perspective. So I would say these three countries are well equipped to provide and capture the patient's perspective, and we have seen success.
Great. And Mike, did you have anything to add to that?
No. The patient perspective is one that I think most governments need to work much more to try to incorporate within the decision-making process. From an HTA perspective, I think Germany is a very unique system. It is a system that does provide for free pricing for the first year as part of the process. That allows to access innovation, which I think is helpful. It does have a political entity that oversees the health technology assessment group, and then often reverses their decisions in that process. And so there are some different types of safeguards in Germany that you don't see in other markets.
Great. And then one last question, and I'll turn it back over to Dave to give us direction on how we're going to move forward. We have a question that came in that says, is anyone on the panel aware of a Scottish medical consortium, which is an HTA agency? And they have apparently a patient and clinical engagement process where patients and patient groups have a clear pathway or access to the process. Are we familiar with that? Anyone on the panel?
We certainly interact with that group. I'm not the person that's most familiar with them, but we certainly interact with the Scottish group.
We are aware that the patients in Scotland participate through the whole process, collect their views, they have a role in the appraisal. So yes, but so it happens in Germany. But as Dr. Ryan said, there is a structured way for patient participation in Germany, then they can participate through the whole process and they can contribute to the methodology of the assessment and sit in the appraisal committee. But apparently is what we have noticed, that the patients need empowerment, education of how to utilize these benefits that they are given in some of these countries. Some of these countries do provide the facilities, do provide the structure, but the governments need to support further, as well as the patient organizations, the training of and the knowledge of how to express their patient perspective in these positions and processes that they are given opportunity to contribute. So right. Yes, in Scotland, Germany, Australia and Sweden also patients, we've got patients which are included actively in the appraisal committee.
Great, thank you, Dr. Andrula. Let me just end by asking Elizabeth and then John, any final thoughts that you'd like to leave the audience with? Any final sort of factoids, as I call them, or tidbits that you'd like to sort of leave as takeaways?
Yeah, as we're having this conversation, I was just thinking about at one point I was on an ad board and an insurer said to me, well, patients just want what they want when they want it. And I said, But if you actually listen to what patients want, not everybody wants the most aggressive treatment. Not everybody wants, some people value quality of life. Some people value many other things. And if we actually listen to patients and cater to what their values, needs, and preferences are, not only would it be the humane thing to do, but I think it also would save money in the long run, because you would find that not every patient wants everything at every moment. And so I just think that comment has always stuck with me, and I think it really informs the value discussion. So, patients want what fits their needs and values, and we need to listen to them.
Very well stated. Thank you. And John, can you close us out? Any last words or thoughts from yourself?
Yeah, I just say that the patients and people that advocate for them are really smart, and they do a really good job of educating themselves about the disease states and the hope that may be coming in the form of new innovation. There's precious little accurate information out there about some of the things that Mike so helpfully summarized today. We have on our website and now on the Advocacy Exchange website a couple of resources. One is a current landscape of value assessment frameworks. It's a great 101 primer on the strengths and limitations of U.S. value assessment frameworks, and Mike pointed to some of that earlier, as well as a second document on underestimating the value of an intervention. So the case for including productivity and value assessments and formulary design. This research shows that including non-healthcare costs like productivity in value assessment frameworks can really change the answer that you get in a value assessment framework when looking at an intervention.
Thank you, John, so much. Thank you to Mike for the keynote address. Also to Elizabeth, John, Dr. Andrula, thank you so much for joining us today. I'm going to hand the session back over to Dave. He's going to give us a bit more information to the individuals that are staying with us, and we're going to transition to the working groups or presentations. Dave, over to you.
Wonderful. Thank you, Stephanie, so much for such a genuine panel and conversation. And thank you to all of the panelists, not just for sharing your time, but for how much of your heart and mind you put into all of this work. It is reassuring to know that this is happening, and that doesn't mean that we want to let up. And so I encourage everybody in the audience, whether you're an advocate or a patient or a caregiver, to really get involved in this conversation. And I was so glad that John mentioned the resources that are on the advocacyexchange.com platform 24/7. Please check out more there and leave us comments. I am going to quickly turn it to the final section of our session today. In the Advocacy Exchange, we have established 4 working groups, and these working groups are directly tackling some of the top priority issues that we heard from the advocate perspective. And so these groups were co-created and are now being led by advocate leaders and by advocates and patients from around the world. And so we're honored for you to have an update from these individuals, and we hope that you'll join that conversation. So check out the Advocacy Exchange platform for the next live session. We would love to include your voice in those conversations. With that, I see Neil Bertelson is on camera. And Neil, I am honored and grateful to turn it to you, sir.
Thank you very much, Dave, and it's lovely to be here again. And I just want to give a really quick overview of where we've got to in our working group. We've been focusing on the patient voice in drug development and how that can be more integrated and more representative. And so we've been on a journey, but there's been some really key threads to this journey that have followed us all the way. What we heard consistently in our working sessions is the need for a more consistent and open approach to bringing in patient input and patient insights into medicine's development. One of the things that we want to avoid is almost having a two-tier system where a select group of people are inputting into drug development, but the wider patient community and patient advocacy community are somehow locked out of that. And so what we've done over the last few months is work on a set of principles that really help us to underscore what we think needs to be that direction of travel, that journey. We want patient involvement, patient input into drug development to be open and inclusive. We want it to represent the diversity of the patient populations for each of those diseases, for which drugs are being developed. We think that capacity needs to be built on all sides, but not just, too often we talk about this in terms of the patient advocate community needs to have better capacity. And what we're saying is actually, no, everybody needs to be building capacity. The industry needs to be building capacity. The academic research community needs to be building capacity on how to work with patients. Regulators, we've just heard about HTAs. They too need to be building and strengthening their capacity. But once we've got those insights from patients, from patient advocates, it's making sure we're sharing them as openly and as widely as possible. There simply isn't enough resources amongst all of us to keep doing this over and over again and answering the same questions. So we want to make sure that we're sharing those insights that are developed as widely as possible and not keeping them behind firewalls. And if we've got to reach to patients and really a diverse range of patients, we need to start thinking about new engagement models. So how do we get input from a wider group of patients? What can we learn from new technologies and new digital tools that could help us do that? So we've explored these principles and we're writing those up at the moment. And one of the things that we've talked about recently is how we bring in other stakeholders. So this is not just a conversation from the advocacy community saying, this is the world as we want it to be, but it's actually saying, this is the world as we want it to be, and how can we all work together in a multi-stakeholder sort of way to make this happen? And so that's a very, very brief summary of where we've got to in our working group. And I think I'm passing over to Brad now.
Indeed you are. Thank you, Neil, and hats off on the excellent work to date. Certainly those principles are the things we're trying to get to, because that's how, as you say, maximizing the input of various stakeholders and those guidelines that come through principles are how we create systemic change. In the Access to Care group that I'm running, work is similar in some ways, that we have also been having ongoing conversation about who the stakeholders are and who's missing in the access to care conversation. Particularly, this is critical because within access to care, the barriers are so profoundly different by geography, by diagnosis, by culture, by all of the things that make humans human fundamentally. So it is quite a broad task to think about how to improve access to care. But the way we've been approaching it and where we're going to go going forward that I could not be more excited about is to continue diving into what is known in the space already. So for example, we've gathered all of the best practice guides we could find that are put out by professional associations and organizations and researchers and all of the projects about how one assesses and improves access to care. And the thing that we have found, which is where our opportunity lies, is that amidst all of this, there are almost no patient voices as stakeholders. There's almost no advocacy voices in these broad documents about best practices and access to care. For example, there are a lot of documents about how clinical managers feel about access to care. And that's important. They're a stakeholder in this, but we also need the advocacy voices. And so our work going forward will be to start gathering that data, to start having conversations with you about what access issues look like within your domain. And so we're excited to move on to that. And that's part of how we can all be part of systemic change. Speaking of which, I will pass it to Sheila, who is a longtime leader in systemic change that we all enjoy the chance to learn from and aspire to model. Sheila?
Thank you so much, Brad, and thank you to all my co-leaders and the extraordinary presentation we enjoyed. I would be remiss before I give my update for my working group, Racial and Ethnic Health and Healthcare Disparities, by acknowledging Indigenous Peoples Day that we all recognized on Monday. American Indian, Alaska Natives, and other indigenous groups that have contributed so much richness to the American mosaic. And I hope each of you took some time to think about those contributions. In any event, my group definitely has an enormous task because COVID-19 has thrust the healthcare world into a reanalysis and a prioritizing of racial and ethnic health and healthcare disparities. which have been persistent and pervasive for decades in America. But now all of us in the health ecosystem are realizing that this must be approached in a very special way. So my group is a passionate, very outspoken, and a very diligent group to really stand firm with regards to personal advocacy, family advocacy, community advocacy, and also for the populations that they represent. But we didn't want to start from zero. And there's been a lot of work in the disparity space. In fact, in 2007, there was a commission to end healthcare disparities that was developed in response to the Institute of Medicine report on unequal treatment, which definitely documented the existence of disparities in spite of income and access issues. This commission was made up of over 50 professional medical societies and organizations. And in 2007, they came up with 10 guiding principles, so that my team and my group is looking at, are those principles relevant to the advocate? That's a very top-down approach. What about a bottom-up approach? So we're taking a look at those 10 guiding principles to see whether or not we can apply that to an advocate's life and an advocate's vision and mission. And so those core principles will lay the groundwork for what we hope to come out with as the gold standard, as best practices. What is an advocate, and how can an advocate, in spite of the disease state issues, deal with the barriers of systemic, structural, and institutional racism? That, unfortunately, is the cloud under which these advocates work, and we have to acknowledge the existence of that data so that we can realistically begin to chip away at and dismantling and eliminating racial and ethnic health disparities. So we're excited. We continually have this conversation. It's now more relevant than ever before as America begins to brown and age very differently. So with that, I'm going to pass it to my other working group colleague, Gary, who's going to give us a sense of what his group has been doing. Gary?
Thank you, Sheila, and thank you, work group leaders, for teeing me up. So I've had the privilege of leading the session on the future of advocacy, which was quite a broad topic to start with. So the working group that I had was attended by many representatives from across the US and Europe and even further afield. And we started to initially look at what is the meaning of advocacy and what does it mean to the individuals in our group. And what we very quickly found out that advocacy is very personal. It's down to the individual's impact by that disease, whether it being a personal impact, a professional impact, or an impact caused by the healthcare system that they are working within. So advocacy, very quickly, the future of advocacy is unique to individuals and what they believe it is and will be. We also discovered quickly that COVID has had a huge impact on the future of advocacy. We have been forced to find new ways to deliver what we believe advocacy is, whether that is through embarking on new collaboration opportunities, on using technology to provide our advocacy efforts through, or just working as a community across therapy areas to share learnings as a result of COVID and being forced to work in different ways to provide what we believe advocacy to be through. That then took us on to looking at some principles around advocacy. So if we had to start to categorize what is advocacy, what would that look like? So our group quickly then stumbled across or worked together to come up what they believe were the core principles or possible principles of advocacy. And they were care, providing personalized and individual care to a group or an individual along their journey. Empowerment, empowering patients and their loved ones to advocate for themselves, or at least seek a standard of care they're entitled to. Access, advocating for patients and carers to ensure that they have access to the latest treatment options available to them, or once again, a minimum standard of care. Awareness, helping drive awareness of a disease or a new approach to care in a therapy area. Supported research, so ensuring that continued research happens in a certain area. And then policy, ensuring that healthcare policies really reflect the needs of patients. So the group essentially came up with these core principles of care, empowerment, access, awareness, research, and policy is what the principles of advocacy may look like. And we then took that one step further to look at what some of the possible standards are that support those principles. And they fell around, if we had to do a one brush stroke on what would sit across all of our principles, it would be that everything that we do needs to be patient-centric. Patient-centered, looking at the needs of the patients and the carers. Then holistic, not just necessarily looking at the patient themselves and the disease itself, but looking far beyond that and what other impacts the disease may have on that patient. Comprehensive and individualized, ensuring that the care, the support, the awareness, the research that goes into patients is comprehensive, but once again, as we heard in the previous conversations, individualized. Personalized medicine and targeted approaches to treatments are becoming the future of medicine. So we need to be constantly thinking about providing comprehensive and individualized care. And then the last one, which I think is a really important one based on today's conversation, is evidence-based. The advocacy efforts that we provide need to be based on the evidence and the needs of the patients. How we collect that is a very big topic for discussion, but evidence-based. So we've been working as a group just to sort of identify some overarching principles of the future of advocacy, and then what some of the standards could possibly look like. And that's then resulted in, how do we help groups communicate their definition of advocacy? How do we support an advocacy organization in Israel communicate to healthcare authorities about what they do, whether it's empowerment, whether it's access, awareness, and so forth? So building capabilities, as Neil mentioned, how do we help capacity build within groups to help them communicate their definition of advocacy to various stakeholders, whether it be policymakers, healthcare professionals, industry, and so forth. So we hopefully be looking at next year in using these principles and standards to create tools that will help advocates communicate their definition of advocacy to a variety of our stakeholders. And I'm now going to hand back to Dave.
Thank you, Gary, all of our working group leaders. If I can ask you to just stay on for one more minute before we close for just a quick thought before we part ways for today. Each of our working groups, you've done so much listening this year in the group from different perspectives, from different stakeholders. And I would just love one closing thought. And maybe if I could go Brad, Neil, Sheila, and then Gary. Brad, as you think about where you go next with these principles and what access means in your group, how do we invite people to be a part of refining and defining that? We need people in this conversation because.
We need people in this conversation because they've never been heard. And we have the chance to legitimately listen for maybe the first time in some spaces. So we owe people that at a minimum.
Powerful. Sheila, the work I've gotten to do with you, sorry, I skipped. Brad connected me to our work, and Neil, I apologize, I skipped right to Sheila. Sheila, the work that I've gotten to do with you in the working groups has made me realize just how recent any change is and how much more is needed. What is your words to people who are just getting involved? We need them here because.
Yes, thank you, Dave. There's no doubt that the solutions to healthcare disparities are complex because it's multifactorial and it's multi-layered, and how we got here is certainly a history that we need to understand. 1985 was the first time the disparities were documented. And here we are in 2021, still talking about some of the same issues. So we definitely want people who don't look like us, who don't speak our language, who don't come from where we come from at the table. Because as Brad and all of my colleagues have said, their voices need to be heard. And so advocacy on that level really goes to the heart of why we are in healthcare, to make sure that everyone has a quality and longevity of life and equity. We each have the opportunity to achieve our best health. So we want difference. We celebrate difference. We welcome difference. So please join us so that we can hear your voice.
Sheila, you said in one of your sessions that there is more difference within our groups than across them. And every time I'm exposed to new perspectives, I realize how much we are all trying to be a part of more equitable care.
Absolutely.
Thank you. Neil, you've taken us this year through the really sophisticated process of HTAI development and into patient voice. We need people in this because.
We need people in this because these are difficult problems. We live in a complex world, complex healthcare system, complex decision making, and for too many years have people sat in their ivory towers and said, we know best. And I passionately believe that we have to avoid doing that as well as the advocacy community, that actually only together by listening to many, many different kinds of advocates and patient groups and patient representatives and diversity, but other stakeholders as well, bringing in the healthcare providers, bringing in those who have the power to control the healthcare system, bringing in the industry, bringing in those other stakeholders. Everyone has a piece of the puzzle. Everyone has part of the answer. And we need to start listening more to each other and putting ourselves in each other's shoes. And through that, we can start to learn about what are our individual barriers. What, as a healthcare provider, what barriers do I have to overcome? As an advocate, what barriers do I have to overcome? And by exploring those barriers together, we can come up with solutions that meet everybody's needs, I believe.
Neil, in one of the working groups this year, I had the realization that it has taken me longer to overcome my own barriers than people's willingness to accept me. When I'm able to overcome, people are readily not only able, but want to accept. And so what you just said is so powerful. Thank you. Gary, as the Future of Advocacy Working Group leader, whether people are 3 days or 3 decades into advocacy, we need their voice because.
Well, I think the discussion so far has been around the future of advocacy, but more importantly, the future of healthcare still hasn't been defined and still needs to be defined, which is a lot bigger picture or conversation than advocacy itself. So, why we need involvement and the voice of the community is because it's the sum of the parts. And, by defining the future of advocacy, what we're actually doing is helping define the future of healthcare. And as we heard through on the discussions today around different healthcare systems, different approaches to access to drugs, there is a lot of work that needs to go to accelerate and expedite, fair and equal access to novel therapies. So I think my summary is without involvement of the patient voice, the patient advocates, we can't really define the future of healthcare without, individually defining the future of advocacy.
I agree completely. I hope everyone in the audience feels invited and included to join these working groups. The rest of this session, we will be gathering more input and then going into 2022 with some specific outcomes in mind that we want to co-create change together. So I'd like to wrap this session by thanking our working group leaders, not only for today's update, but for all of the work that you've been doing this year. We've really made some progress, and I'm hopeful more than ever for where we're heading with it. I want to thank our speakers and the panelists from the earlier portion of our session. It truly is such a complex topic, and I gained some really good knowledge and more connection to this than I felt before. And I, of course, want to thank our Grit Health team, who behind the scenes puts miracles together and makes incredible things happen, and our founding partner, Bristol Myers Squibb, for bringing this program to life and for believing in tackling really big and really challenging problems. We will make progress together. With all of my heart, thank you, everyone. Have a great day.